Good afternoon and welcome to the Black Health Trust weekly program. We're so pleased that you've chosen to empower yourselves today by joining us. It's great to have our regular attendees back and those new to the program. My name is Janelle and I'm your hostess for today. I hope you all are doing well from wherever you're joining us from. Today, our panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation and President and Founder of Black Health Trust. He will introduce his terrific co-moderators and guest presenters today. Black Health Trust was founded in response to the global pandemic and Dr. Maxey's desire to keep his own family safe. And fortunately for us, his commitment evolved into a much larger vision. The purpose and mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines to offer unvarnished opinions and insights into our physical and mental health during these challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioners. I'll start by sharing a few housekeeping items and announcements for the program. First, this video conference is a live program and being recorded on different public platforms like Facebook Live and YouTube. Your participation in this program is completely voluntary, and if you choose to participate and prefer not to have your image and likeness displayed, there are visual and audio settings on your personal device that you can use to block your picture and mute your voice. That said, all participants will be muted by our Zoom technician initially. We ask that you remain muted until the host or moderator asks you to contribute. That is in order to minimize the distraction of background noise so that we can give 100% attention to our speakers. Check and make sure that your device is on mute, please, until called on to speak, and then once again, place your device back on mute when you're done speaking. In regards to the chat room, if you have questions, you can enter them into the chat room. Please limit your questions to 2 questions per topic being addressed, and please do not use this forum to advertise or promote your products. Understand that there may not be sufficient time to get to all of your questions during the call, but we will do our best. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone. Nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult their own legal and medical professionals for conclusive guidance on how to proceed in your own personal circumstances. We are in this together. If this program has been valuable and interesting to you, please visit the website to learn more about our programming and how you can support Black Health Trust so that we can continue bringing our community outstanding content. Visit blackhealthtrust.org. We want to thank the Black Health Trust Steering Committee, the Executive Board, its virtual administrative assistant, our production and Zoom technician, Black Health Trust supporters, and all of the people behind the scenes for their time and efforts that make the program possible. Let's now welcome all of our distinguished physicians and special guests. We thank you for sharing your valuable time, information, and educated insights with us today. Your participation and support help to empower our community of color, and this is critical to our present and future well-being as people. Black is beautiful and knowledge is power. Welcome again, everyone, to the Black Health Trust weekly program. This is our community. This is our time to take care of our health. So lean in, everyone. Dr. Randall Maxey, please do us the honor of beginning today's program.
Thank you so much, Janelle. We appreciate you. I thank our distinguished guests, Dr. Gibbons and Dr. Dispani, for giving us their time to join us today. And I appreciate my 2 distinguished co-moderators, Dr. Barbara Nabert-Stevens, a noted pediatrician and officer of the National Medical Association, and the distinguished Dr. Ivan Walks, psychiatrist and former director of the Department of Health. I think I got that right, for the city of Washington, D.C. Thank you so much. I want to go right to the questions that we want to speak to our first guest, who is Dr. Gary Gibbons. And Dr. Neighbor Stevens, can you tell us very briefly who Dr. Gibbons is?
Good afternoon, everyone. It would certainly be my pleasure to introduce Dr. Gibbons. Dr. Gibbons is a director of the National Heart, Lung, and Blood Institute at the National Institutes of Health, where he provides global leadership for research, training, and educational programs to promote the prevention and treatment of heart, lung, and blood diseases. And it is in that capacity that we invited him to talk with us today about the impact of COVID and these comorbidities. So without further ado, I turn it over to Dr. Gibbons.
Dr. Gibbons, I'm going to ask you the first questions, if that's all right.
Sure.
I first knew you as distinguished professor at the Morehouse, and years ago, and now it's good to see you in this role.
Likewise.
But we know that everyone should be getting the vaccine, but there's a lot of concern about whether the vaccines will protect against the variants that have been identified recently, especially the one from India. Has there been any progress in improving outcomes for people who get sick?
Again, thank you for having me, and thank you, Dr. Maxey, for this kind invitation, as well as that question. As you're aware, part of our engagement in NIH involving the Community Engaged Alliance Against COVID-19 Disparities was very early on. We were engaged with actually nearly all the major companies that were undergoing vaccine trials. Quite frankly, we were leaning in to ensure that there was inclusive participation, particularly in communities of color that were being most adversely affected by the pandemic, in all the trials that would test safe and effective treatments, both therapeutic as well as vaccines. And so we are pleased that related to those efforts and others, that most of the vaccine trials were indeed inclusive, with, in general, about 30% Latino and African-American populations. We thought that was important because as these things were reviewed by the FDA, we wanted to be ensured that there was a sufficient body of data that actually confirmed that these drugs were safe and effective in communities of color and participants from those communities with their lived experience. And so in that regard, your audience should take some assurance that people who look like them participated, actually were investigators in the trials, were member of the data safety and monitoring boards, the independent boards that monitor and ensure the safety of these drugs, as well as, quite frankly, some of our colleagues on the FDA advisory board that helped approve these drugs, again, from communities of color and representatives of historically Black medical schools, were involved in this process from beginning to end and from top to bottom. And so therefore, our community should have confidence that indeed their interests have been tracked and that these agents are indeed safe and effective. And therefore should have confidence in receiving them and following the CDC guidelines, as well as the FDA guidelines, that they should be vaccinated. As you point out, those vaccines were originally designed against the virus as it originally emerged. One of the things about this technology, though, and I'm sure my colleague will describe it further in his expertise as a virologist, is that this novel coronavirus, SARS-CoV-2, is a kind of virus that is an RNA virus. And so it is capable of morphing and changing. And in so doing, it has evolved even since those early days, late in February and March of last year. And as you point out, different variants have emerged. And as this virus has evolved, I think the good news and a key takeaway is that for the most part, For those who receive full doses of the vaccines that have been shown to be safe and effective, these agents are still pretty effective against most of the emerging variants that we've seen thus far. Part of that evidence is related, for example, in UK, United Kingdom, in which that Delta variant that is just now getting a foothold here was actually the predominant variant in the UK. And yet, those who are vaccinated there, it's holding up pretty well with these original vaccines. And so that gives us some confidence that indeed this first generation of vaccines are very effective. But it does tell us that we're in a race against this virus. And so that's why it's so critically important for all of us to get vaccinated as soon as possible to protect ourselves, our loved ones, our community. And that, I think that's the key take-home message, because quite frankly, there is the possibility that new variants will emerge that may erode that protection. And this is the time to get protected as it gets more infectious and potentially more virulent.
Dr. Neighbor-Stevens is going to ask the next question, but I'd just like a brief follow-up. Not often do we get to meet a physician who has a larger responsibility as you do. Could you just briefly describe your responsibility at NIH and what the mission is of your particular division?
Well, as you know, Dr. Maxey, this is a position of public service, and it's my privilege to have it, in which I direct the National Heart, Lung, Blood Institute. That's a $3.5 billion research agency. And so as part of that institute, as you know, this virus attacks the heart, the lung, and the blood systems. And so that falls into the portfolio that we're responsible for. And so a key part of the overall NIH response, the NHLBI was going to need to be at the vanguard. In addition, we've had a longstanding and passionate interest in addressing health disparities. And it was very clear from the beginning that there was health inequities that are being laid bare by this pandemic. And indeed, many of those at greatest risk have conditions such as chronic lung disease and heart disease, so prevalent in the African-American community. So for a variety of reasons, we've been on the front line of this NIH response from the beginning. Moreover, I just might mention that the NIH director charged me and Dr. Eliseo Perez-Stablo, who's the director of the National Institute of Minority Health Disparities, to develop a new program, a new initiative we call SEAL, the Community Engaged Alliance Against COVID-19 Disparities, that specifically vanguards the NIH response to COVID-19 disparities. So it's with a number of those hats that I'm here today.
Well, thank you. Dr. Neighbor, you have some questions, I think.
I do. Thank you so much. Hi, Dr. Gibbons. You know, we are very proud of the fact that you're at the NIH, and we have been very focused on the COVID devastation that we have experienced. But before COVID, heart disease was ravaging the African-American community. So we would like for you to comment on some of the ways in which your agency has been tackling this burden on the African-American community.
Right. Well, it's again a great question. As you pointed out, the pandemic has again amplified the health disparities, some of which that it pre-existed long before COVID. And as you also point out, that we know that the most severe forms of COVID-19 tend to occur in those who have comorbid conditions such as diabetes and high blood pressure. And so we knew that African Americans with those disorders would be most adversely affected. But you're quite correct. A key part of our portfolio has been to understand those health disparities and develop interventions to address them. And we have a variety of programs that involve the community and engagement of communities. For example, in promoting hypertension control, we have a program called Decipher that's engaged in that process. And in fact, part of our NIH response to COVID-19 was to leverage those pre-existing networks of investigators, community engaged researchers who already had developed long-standing relationships in the community, often partnering with community-based organizations, other stakeholders. And that actually accelerated our ability to marshal really grassroots and frontline folks, like some of those on this call, to be partners with us, such that we could roll out and address a lot of misinformation that was out there about COVID-19. I won't amplify the myths, but indeed giving credible, authoritative information, letting the science lead, and addressing that misinformation and myth busting. Moreover, a key part of our effort is to address mistrust. As you know, in our communities, there have been some concerns about new treatments, new technologies, access to them, and we thought that was critical. And it's in so doing, we partnered with, again, folks like those on the call, whether it's the National Medical Association, NAACP, National Urban League, faith-based organizations, a lot of stakeholder groups around the country, both national and local, to really bring together the Black community and Black leadership, Black media, to get those messages out. And I'm encouraged because as of sort of last fall, we had rates in the African-American community of about 40% who said, oh yeah, I will take the vaccine if it's FDA approved and shown to be safe and effective. And I think as a result of that collective community effort by, again, leaders both national and local, that those polls have started to turn around, such that now African Americans are in the 60 to 70% who are willing to be vaccinated. So that's progress, but I think you all know that we still have work to do to get that message out. And we're, again, appreciating forums like this to ensure that everybody's getting vaccinated.
A quick follow-up to this question. What, if any, suggestions you would make to our audience that may want to do some follow-up on heart disease, how it can be prevented, where good sources of information might be obtained that are related to your agency? Well,
certainly they can come to our website, just plug in NHLBI or and you'll find us on the web. And we have a host of resources about the best diets that lower blood pressure, like the DASH diet, and how to exercise and keep yourself physically healthy and heart healthy. And in addition, all of our research programs that are available. I'll also give a shout out to organizations like the American Heart Association, Association of Black Cardiologists, that also have a wealth of information relevant to your audience.
Thank you. Dr. Maxey, you want me to continue?
And Dr. Walks?
Thank you, Dr. Maxey and Dr. Neighbor-Stevens. Good afternoon, Dr. Gibbons. Once again, thank you so much for being with us. It is a real honor and pleasure to have you. The question I have for you is, how is the NHLBI addressing COVID-19 disparities and the impact on minority and also on rural populations?
Again, a very important point, Dr. Walks. This is actually, we just launched one of a new team for our Community Engagement Alliance Against COVID-19 Disparities in the DMV area. And so this is an initiative that's now in about 21 states across the nation, where we specifically targeted regions of the country that, again, have a high proportion of communities of color that were most adversely affected, both Black and Brown, literally throughout the country, but clearly concentrated in states like California, Arizona, Texas, with higher Florida, with high Latino populations, as well as the Southeast, Louisiana, Mississippi, Alabama, Georgia, North Carolina, as well as the Midwest, Arkansas, Missouri, Michigan, and Chicago, New York, Philadelphia, and the DMV. And clearly, all of these teams are coalitions of community-based organizations, researchers, faith-based organizations, civic organizations, local coalitions that are bringing these things together. And literally, they're the ground troops. Many of them are going door to door. They've been having, pop-up for testing, pop-up for vaccinations, open mic sessions to develop messages that will resonate with these communities. They're out and literally going door to door, handing out masks as well as information about the vaccines. They're encouraging inclusive participations in research, whether it's clinical trials for vaccines or therapeutics. So they're the ground troops that are doing this work all across the country, having town halls, focus groups, and et cetera, all trying to both listen to the community, leverage the wisdom of the community, and involve champions within that community. In fact, our research indicates that when you ask folks on the ground, who are the most persuasive folks, some might have thought, having a PSA by Oprah would be the turning point. But what we're finding is it's really local trusted messengers, your neighbor, your pastor, your local doctor, who at the end of the day is probably going to be the most persuasive voice to nudge you from, let me wait and see, to, I think I ought to get that shot and protect our family and our community. I want to go back to church on Sundays, and this is the only way to get there.
So Dr. Gibbons, thank you so much for that. Just a quick follow-up. You mentioned earlier that you would not dignify some of the things on the internet about concerns and this and that. But here's a question. Are you, and I think I know the answer, but are you all keeping an eye on things? Everybody was watching as the vaccines were being developed and as they were coming through the FDA approval process and all of that, and the CDC. And I think folks just want to be assured that everybody is still watching, still looking for any problems with the vaccine, still looking to see if folks are tolerating them well, just so people can continue to feel comfortable that it's not over. Take a vaccine and go home, but you all are still, with all those groups you mentioned, that you all are still connected to the community and still looking to make sure that people are staying safe and the vaccines are continuing to be safe.
No, absolutely. Again, excellent point, Dr. Waltz. This is part of vigilance I think we all collectively have. That's one of the reasons why we appreciate the work of our SEAL Alliance, because they're on the ground. They're listening to folks, literally having focus groups continuously to find out what is the latest myth that seems to be circulating and how can we address it head on. And so with authoritative science-based information. So you're right. We were on constant vigilance. We talked a little bit earlier about the variants that are out there, these different strains of the virus as the virus evolves and mutates and changes and shifts up to try to become even more infectious. So those are very active areas of ongoing surveillance and investigation. As you also pointed out, although we do the vaccine trials, and we were being very vigilant about what was happening there and the participation, just because it was FDA approved doesn't actually mean that those things are over. All those participants are still being followed for potential safety issues. Now, most of the time, those occur in the first 90 days or 120 days. So that's why we're confident they're safe. But as you've probably, your audience is probably aware, there have been some rare side effects that have been noted. Those tend to be 1 in a million. You're not going to see them in a clinical trial, but they are, again, 1 in a million. And so, yes, a recent one in terms of an inflammation of the heart, myocarditis has emerged, particularly amongst some of the adolescent age population. Again, very rare, very circumscribed. Generally, all the participants have recovered. But those are the things that we are very vigilant about. The net bottom line, though, is these are highly safe and effective vaccines. The clinicians around this audience, this table know vaccines been around for literally over a century, and all of us had them when we were kids, and some of us again get our flu shots every year, and so we know how this technology works, and these are amongst the most safe and effective vaccines that are around.
Thank you so much.
Dr. Gibbons, I'm very happy, like or many others, that it seems that we're starting to see daylight at the end of the tunnel as far as COVID is. But being a practicing physician, I have a number of patients who've had documented COVID and tested positive at that time, have since tested negative, but they still have symptoms. They still have weakness, they still have brain fogs, they have postural, orthostatic hypotension, what has been called the Longhaul Syndrome. And in fact, we have at the Black Health Trust have teamed with State University of New York Downstate Medical Center to have the first international symposium to discuss Longhaul Syndrome. What is NHBLI doing to better diagnose and treat or even explain what that is? And are communities of color at more risk? I'm concerned about that.
Yeah, no, again, it's a superb question. That actually is one of the other more recent elements of our agenda. As you point out, we have observed, and we've been monitoring this since the earliest reports, maybe in the late summer, of this sort of delayed sort of recovery, the persistence of symptoms, fatigue, poor exercise tolerance. As you said, the neurocognitive, difficult thinking, concentrating, sleep disturbances, and indeed, as you pointed out, palpitations affecting maybe a dysautonomia kind of syndrome, where again, people feel lightheaded when they stand up. So those lingering symptoms are surprisingly prevalent. We're still trying to nail down how much. And in fact, again, Dr. Collins charged a number of us, Dr. Fauci, Dr. Korshitz, and myself, to co-lead an effort in long COVID, the post-acute sequelae of COVID-19. We call that initiative Recover, researching COVID to enhance recovery. And so we're literally in the midst of launching this national program. We're appropriated by Congress $1.1 billion just to study this. And so this is a high priority. As you point out, we're still learning about its incidence, prevalence, who's at risk to develop it, why is it persisting? Is this reflective of some immune response to the virus? Or is this sort of an autoimmune set of syndromes or post-viral syndrome? There are a number of research and clinical questions. And certainly those who are suffering, a key part of the urgency is to see if we could figure out who's at risk, what could we do to, if we understand it better in its full spectrum, to prevent it or treat it more effectively, such that we can accelerate the recovery. So these are active areas of investigation. Indeed, we're in the midst of awarding those cohorts, so it's still confidential information, but suffices to say that we will ensure that there's inclusive participation in this space as well. To address your question, Dr. Maxey, one series that did come out was out of the Veterans Affairs, the VA system. As you know, that's particularly diverse populations, often useful in understanding health disparities. And as I recall, their data set, which is pretty large, about 20% were African-American. So your intuition, I think, is going to probably turn out to be spot on, that this is going to be something where there's a risk, particularly for those who had a lot of exposure, such as those from communities of color, and who often experienced not only the exposure, but some of the complications. And we're still trying to understand what that exposure does to those who had a pre-existing condition. So in other words, if you already had some heart failure pre-exposure, then you get acute COVID, and then you recover from acute COVID. Does that in any way change the trajectory of the disease that you had pre-COVID, such as heart failure or cognitive decline? Is it accelerating that? And there's starting to be some clues. I know you're a nephrologist, Dr. Maxey, that, what did that do to a decline in your kidney function? Did it put it even on a more precipitous decline? Those are the kinds of questions that we're pursuing. Similarly, diabetes and its emergence. So this is going to be, I think, a key thing to keep an eye on, and indeed part of the NIH response.
Well, thank you. As a last question, I want to just deviate a little bit. So many people have what I call, as a private practitioner, the bread and butter diseases of our community: the high blood pressure, the diabetes, the obesity, et cetera. And I read something recently that suggests in older people, senior citizens like Dr. Walks and a few other people, that blood pressure control at 120/80 or lower increases longevity. And just as a matter of advice, as a director of NHBLI to our community, what do we want to do about good blood pressure control, good hemoglobin A1C and diabetic control, obesity control? As our top cardiovascular officer in the country, what would you tell our people is a good set of values that they should know about?
Well, I guess one way to answer it is to move as far as we can toward optimal health. Actually kind of like the AHA's sort of simple 7, other sort of markers, but in many ways it's making sure that you're eating a healthy diet, plenty of fruits and vegetables, lean sources of protein, whole grains, making sure that you're moving and you're physically active. Doesn't mean you have to do a mini marathon every week, but just making sure you're getting bursts of activity, 10 to 15 minutes all the time. Try to squeeze it in, particularly with these Zoom calls. It can be challenging, but just standing and moving, walking and climbing stairs. Those are little things we can all do across the lifespan. Keeping that cholesterol as low as possible. And indeed, what we're finding is the lower you go in general, the better. And quite frankly, blood pressures turned out to be the same way. The optimal blood pressure of 120/80, the closer you can get to that and stay there for as long as you can, generally is going to do you well. And certainly shouldn't be smoking and maintaining a good body weight. Those are all good things. Keeping that hemoglobin A1C in that normal range. You're on it, Dr. Maxey. So all those things, working with your doctor to do that. But if your audience heard me, a lot of those things are choices that we make. And indeed, we're also hoping that we're rolling out programs to make sure that our communities are conducive to that healthy lifestyle, that there are places that are safe and comfortable to walk, and that there are the kind of access to healthy foods in our neighborhoods. And so some of this also involves creating those environments where we can be healthy together as a community. I'll stop there.
Yeah, well, I sure appreciate you giving up your time on Sunday to come and visit with the Black Health Trust. And we invite you back. We love to have more information from you. Is there any final thing you'd like to say before you bid us adieu, even though you're welcome to stay?
Yeah. Well, again, I really appreciate the opportunity. I just love what you're doing here, Dr. Maxey. Again, I've been inspired by the leadership in every corner that I've gone to. Whether, again, it's the faith-based organizations, civic organizations, professional organizations, across the board, nationally and locally, our Congress folks, Congressional Black Caucus. It's been incredible to watch and work with and partner with leaders such as yourself and those assembled here as we all do what we can to protect our communities. I think that's what motivated all of us probably to go into medicine. Is that we wanted to be sure that people who look like us and came from neighborhoods like us get the best possible care. And this is a situation where science and healthcare will literally is being tested to save the entire world. And we're making progress, but we got to make sure that it's inclusive process progress, and that those communities most adversely affected get the most benefit from that science and all the health knowledge that all of us are creating. And that only happens if it's happening on the ground in our communities. And I think we're the best way to get it there through trusted messengers like you and others on this call, conveying authentic science-based information that empowers people to protect themselves, their loved ones, and their communities. So I appreciate what you're doing. We're happy to contribute in any way we can. Please don't hesitate to call on us. Thank you.
Thank you very much. Thank you so much.
Okay.
Very good. Let's go, Dr. Neighbor-Stevens and Dr. Walks, to our next subject, where we're going to speak about the new variants. But first, I want to make sure that we talk about just a couple of things. We know that our theme is sort of common sense, that no matter what you see on TV, no matter what you hear on the news or see on the internet, we know that common sense should rule the day in protecting yourself, because we do feel that our communities are more at risk than some of the others. And we do know that given these new variants, and I'm sure Dr. Dispani will speak about it, testing is still very important. And I met a young physician a short while ago, Dr. Martin, who has a new testing center right near my office in Inglewood, California. But I want to make sure that there are others who know that we have centers that they need to get tested. And it's a continuing process as long as this virus is live and active in our communities. And we know the good work that Dr. Jerry Abraham, who's been on our program before, is doing with actually providing the vaccinations as well. So we're going to have information on our resources on the Black Health Trust of where you can go in your city or state and be tested. Even after you've received the vaccine, there have been some reports, and I'm sure Dr. Dispani will speak on that, but common sense, protect yourself and your family. Dr. Walsh, would you be kind enough to introduce Dr. Dispani?
I would be honored and happy to introduce Dr. Dispani. Dr. Jordan Dispani is an entrepreneur and medical communicator driven by the challenge of addressing complex problems through biotechnology. Dr. Dispani has trained at wonderful places like Louisiana State University. He is someone that has been investigating coronaviruses previous to the COVID-19 outbreak. He's earned a pharmaceutical sciences PhD at the University of Southern California, and has just been an amazing resource for the Black Health Trust, as well as the larger community. So with no further ado, Dr. Dispani, thanks for being with us, man. We need to unmute Dr. Dispani, please. I think Dr. Dispani is still muted.
Should be on mute now.
There we go.
Okay. All right, yep. Hello, everyone, and I welcome you to the latest iteration of my ongoing series for the Black Health Trust. This one is entitled Virology 401, Learning Pandemic Era Greek. And first, I want to start off with seeing, or rather illustrating where we are against the SARS coronavirus 2, first with the cumulative cases and cumulative deaths. And you can see just from the statistical data that we have a curve, which again, it's supposed to be exponential, but it's starting to plateau out, as you can see. And just as a point of reference, this data was sourced from the Johns Hopkins Coronavirus Resource Center, and it is valid as of June 10th. Now, what we see thus far is that there have been a total of 33.4 million cases total within the United States. And thus far, that has led to a total of about 597.1 thousand deaths. So 597,000 deaths, which is a very sobering statistic. But what we are seeing in terms of the daily cases and daily deaths, that things are kind of on a, I guess, a slow decline, and that things have started to stabilize. Now, that could be owing to two things. One is the fact that viruses, especially respiratory viruses, often have a seasonal trend, hence why you typically encounter the fact that influenza viruses are often in, I guess, hiding or hibernation, typically during the summer months. It's just that it has a more difficult time circulating, and it's the same thing almost with the SARS coronavirus too. And then the second aspect, of course, is the fact that we have now ramped up vaccination efforts throughout the United States, which you see in this this green graph that really has an exponential trend. In fact, thus far, we have vaccinated or administered a total of 307.8 million total vaccinations. And one thing that we are now encountering that could actually upend these very encouraging trend lines are the fact that we now have to worry about this new Delta viral variant. Now, this gets to the crux of the title of the talk, which is Learning Pandemic Era Greek, because many people have often been confused about, like, oh, what is this B117 or B1351 or P1, or, you know, just an absolute alphabet soup, alphanumeric soup, actually. So what actually occurred on June 1st was that the World Health Organization decided to simplify the classifications by instead granting Greek alpha, using the Greek letters of the alphabet in order to list each of the different viral variants. And the reason why stemmed not only from helping scientists have a uniform lexicon, but also because there needed to be a removal of stigma. Because one thing that we have seen in prior pandemics is that there has often been stigma attached to certain viruses, ostensibly because they came supposedly from that area. Like, for instance, the Hong Kong flu back in the 1960s, or even the 1918 Spanish flu, whereas there's never been any evidence that just because those viruses had their first appearance in the media there doesn't necessarily mean that they emerge from those regions per se. So trying to remove any nationalistic aspects from our official classification systems. And then what you will see is that, say, the B117, which is linked to supposedly linked to the United Kingdom variant, has now been renamed as Alpha. And then with B1351, which has mostly been reported in the media as being the South African variant, that is now labeled as Beta. And P1, which the media has labeled the Brazilian variant, is now known as Gamma. B1429, which the media has considered to be the California variant, is now known as the Epsilon variant. Then there's also B1526, which the media found that to be predominant in New York. That one is now known as Iota. And then lastly, we have the variant that has mainly garnered a great deal of attention within the media, and that is B16172. And that has been simplified to Delta, and that is came to I guess, media prominence in India predominantly. And what you see here from a physician named Dr. Eric Topol is that he actually created this nice little table that actually compares all of the variants succinctly in a readily visual format, where you can see, you can compare like the transmissibility rates amongst the different the variants, and as well as their immune evasiveness, meaning their ability to still cause infection and disease, even in spite of, say, being vaccinated. And again, but you also see that there is vaccine effectiveness, and in the far right column, you actually see that the vaccines actually work against all of these variants. And right now, I want to first draw audience members back to the fact that the Alpha variant is actually the source of most of the US infections now. And this was actually something that was predicted by the CDC back in March, and that has actually come to pass. As you can actually see in the figure of the United States in the at the bottom, right, that it's pretty much predominant, with the shaded areas indicating that there are more than 750 cases of that Alpha variant, but it is essentially in all 50 states of the of our nation. And the reason why the Alpha variant was able to become so successful, it largely derives from the fact that it had these 7-point mutations that actually led to increased contagiousness or infectivity or transmission, and that concomitantly also portended higher mortality rates. And what's interesting is that that specifically derives from two critical mutations within the spike protein. And recall that the spike protein is basically just like this knob that binds to the ACE2 receptors that are on your body, and it binds almost like Velcro to your ACE2 receptors that are studied all throughout your body. As Dr. Gibbons mentioned, that this is SARS-CoV-2 is actually a viral disease that infects the heart, lung, and blood, like the entire vascular system. And the reason why is because the ACE2 receptor, ACE2 being short for the angiotensin converting enzyme receptor 2, plays a large role within the vascular system, because it participates in the angiotensin renin system, enzymatically breaking down a larger precursor into something that can then be used to modulate our blood pressure, and et cetera, et cetera. So now you begin to see that you have a virus that is basically hijacking your body's normal mechanism of controlling blood pressure and, basically, like water retention and so forth and so on, and exploiting that so that it can basically enter like a key and into your cells. And then once the key is turned, when the spike binds to your ACE2 receptors, then that's how it's able to initiate infection. And then two specific point mutations that are responsible for this increased infectivity that has led to the Alpha variant becoming the predominant variant in this nation include this N501Y, which again enhances the binding of spike, just like basically it went from Velcro binding and allowing entry to some type of super glue, which now makes it even more makes it even simpler for the virus to enter. And then there also is another mutation called P681H, and that actually is kind of an aspect of the virus which allows it to activate itself. There are younger members in the audience that probably say things like, oh, they went beast mode and whatnot. That essentially is the tantamount to the SARS-CoV-2 going beast mode by making itself easier to activate as soon as it gets in contact with the ACE2 receptor. And it's like, I'm ready to go, let's enter. So then that's, these two are key mutations that lead the Alpha variant to basically become the most predominant variant all really throughout the world. But unfortunately, what we are seeing now is that we're at a critical crux point, or even a paradigm shift almost, virologically speaking, in as much as we are encountering a new challenger in the form of this Delta variant. And what you see here from data sets pulled from outbreak.info is that comparing the blue trend line relative to the orange trend line. The blue trend line is you're looking at alpha, and then with the orange trend line, you're looking at delta. And just plotting that over 2021, you see that there's been a sudden drop in the alpha variant relative to the delta variant. So that is fairly concerning. And then looking at that data within the US, just juxtaposing the United States over these two variants, what you see is that indeed we still have the alpha variant being the most predominant strain or variant, sorry, but we are seeing an uptick in terms of the Delta variant spreading throughout the United States. And the reason why we're able to deduce that is looking at sequencing data. This is very critical. So what we are finding in the United States is that there are over 168,165 different reported sequences of the alpha variant. And basically when I say these sequences, I just mean that these are people that have been tested, and each of these sequences or lineages are all little mutations that have been garnered by SARS-CoV-2, because SARS-CoV-2 is basically like a little collector. It's like, I'm basically trying to evolve, and I want to be my best self. But for a virus, being its best self means trying to run through as many mutations as possible. And what we're seeing is that now with the Delta variant, it is here in the United States, and it's quickly gaining a multitude of different sequences as well as it tries to evolve into its best self. So we have seen that there are actually 2,212 different sequences of Delta looming around within the United States. And that actually means that it has beaten out the Beta variant having 2,159 different sequences. And if you will remember, this Beta variant was referred to in the media as the South African variant beforehand, and this South African variant, now known as Beta, actually had many scientists, vaccinologists, and just the pharmaceutical companies worried, precisely because it had immune escape mechanisms. So let's get to the big deal with this Delta variant. And based off of what we've already seen occur across the pond in Britain, basically this Delta variant has actually outcompeted the Alpha variant. This occurred in May, which basically was just last month. And that was deduced via sequencing data, mainly because in Britain, actually, they're really on top of their sequencing data, in as much as they update their sequencing data and data sets every day, whereas for the United States, there's always a lag time between our sequencing, and that is critical to being able to capture how a virus is evolving in real time. Now, secondly, well, I'll actually just point you to the figure on the left, which actually details how Alpha has been faring against Delta, with Alpha being in this brown color, whereas Delta being in red. And you're seeing that, again, Delta is just totally leaving the Alpha variant in the dust in terms of the number of cases reported that are being sequenced. And what we're seeing is that that is also translating into the number of cases and hospital admissions within the United States. I'm sorry, in the United Kingdom. But even though we're seeing a rise in the United Kingdom in terms of the cases, daily admissions, and then the patients, the deaths aren't really, going up that much. So this is kind of a hint somewhat that the people that are dealing with having to go to the hospital probably have not been vaccinated. Another aspect that it should be pointed out is that the data indicate that the Delta variant may be between approximately 40 to 60% more infectious than the Alpha variant. And again, the way that RNA-based viruses like SARS coronavirus 2 evolve is just through stochastic random mutations. And many of the data sets and research papers that have been done concerning the Alpha variant has actually deduced that the reason why it became so infectious was most likely, and this is just a leading hypothesis because we can't prove this definitively, but the hypothesis is basically that SARS coronavirus 2 infected immunocompromised patients who didn't even have really strong immune responses. So the Alpha variant was basically, the SARS coronavirus 2 just in general was infecting these immunocompromised patients, and it was basically using their bodies as like a training ground, very similar to how you have before you go into combat, right? Say in the Marine Corps, right? You have to go to basic training camp. And that basically was what SARS coronavirus 2 was doing. And then out popped 17 point mutations and also this Alpha variant. And that's what helped the virus, or rather the Alpha variant, become the predominant variant, not only in the UK, but really throughout the world. And now we're starting to see a similar mechanism begin to unfold with the Delta variant, because again, it has already outcompeted its Alpha relative as of last month in the United Kingdom. So that basically indicates what we could have to deal with here in the United States. But now we also need to focus on the secrets behind the Delta variant success, because if you know your enemy, you are better able to fend off against them, right? Yeah, there's a saying by Sun Tzu that if you know your enemy, you'll be able to win 1,000 battles, but if you don't know them at all, you'll never win one, right? And it's the same case here. And what we see is that there are 3 critical mutations within the spike protein of the SARS coronavirus 2 that have enhanced its ability to actually escape our adaptive immunity more effectively. And those 3 point mutations include L452R, which it acts as an escape mutation. And what's interesting is that I had actually discussed my fears about this point mutation earlier, and this point mutation is actually found in the Epsilon variants. And if you will remember, the Epsilon variants, though that's the new name, Epsilon is the new name for the variants that arose in California. It actually arose in Denmark, but then it was really sequenced and got media attention in California. So then it was just called the California variant de facto. So my fears somewhat did come to pass, unfortunately. Secondly, there's also E44Q, which is another escape mutation that actually reduces antibody efficacy. And a similar point mutation called E44K is what really had companies like Pfizer and Moderna worried, because this E44K was already found in the beta and gamma variants. So basically what the Delta variant did is it said, okay, I'm just going to randomly evolve this mutation too. So it's not the exact same, but it's pretty similar. And then lastly, we have P681R, which basically is the Delta variant's version of P681H. And if you remember from earlier in this talk, P681H is what allows the alpha variant to, activate itself and go beast mode as soon as it even gets anywhere near your ACE2 receptors. So basically, this Delta variant is a form of the virus that wants to bind to your ACE2 receptors as soon as possible. And once it gets inside, it is going to do whatever it can to avoid your immune system and your antibodies. So it's trying to make itself more invisible, basically. So trying to bind, faster and more effectively, and then also trying to render itself more of a like stealthy invader. So very problematic. And now you can start to see why this Delta variant has caused so much trouble within India. In fact, in India, there have been horrific cases wherein there have been a series of blood clots that lead to gangrene and also hearing loss. So because of the ACE2 receptor being all throughout the body, this a variant like this, which can evade our immune system, can cause a lot of damage. So what does this mean for our progress? And here I'm actually pulling data from a paper in The Lancet, because I felt that this was a nice figure that kind of illustrated the fact of how even if you are vaccinated, you have to still be, mindful of the fact that the immunity, you're not getting lasting immunity here, but also the fact that immunity is still critical, or at least, getting vaccine-based immunity as well. So what you see here is that on the y-axis, which is going up and down, you see that this is protective vaccine efficacy, and then on the x-axis, you see your fold change. Fold change is just a means of tracking how something should I say this very succinctly? So fold change basically tracks like the difference and magnitude of some aspect, and it doesn't really have units. And in this case, the lack of units would be the neutralizing antibody titer. And what I mean by neutralizing antibody titer is basically the amount of antibodies that can actually bind to and just totally inactivate and eliminate SARS coronavirus 2 within your bloodstream. And titer is just a scientific term for the amount, the number, right? Because these are very tiny. So we typically talk about very small things like antibodies or viruses in terms of their titer. So in this data figure, what you see is that for most people, if they get vaccinated, they start out with immunity, although there are factors such as age or just the fact that your antibody duration actually wanes over time, or even having some types of comorbidity, as Dr. Gibbons discussed before, and that can actually reduce the effectiveness of the vaccine 2x. Now, imagine if you introduce a new variant of SARS coronavirus 2, and it's trying to escape your adaptive immune response, and then the fact that the virus is using these different mechanisms that are based in physics almost to do this, then you start to see that, wow, it just drops from 2x down to almost a 6x drop. So really you're losing 6, 7, 8, you're losing 8x effectiveness. And then from there, they went ahead and they plotted out extrapolated okay, what else might happen that could reduce the effectiveness, and then they would speculate within that range there, that you probably lose another 2x of the effectiveness of your antibodies being able to bind and knock out the SARS coronavirus 2. So another thing that probably should be mentioned, because I did mention the natural antibodies waning. Basically, the data have thus far indicated to us that whenever a person receives the vaccine, SARS coronavirus 2 vaccine, without necessarily having been infected, we can only extrapolate thus far that offers approximately 6 months of protection against SARS coronavirus 2. But again, we're still conducting research studies, so maybe that will be longer, but that's all that the data tell us now. Now, by contrast, if you have been infected with the SARS coronavirus 2 naturally, say you got sick, and regardless of if you got vaccinated thereafter or not, the data indicate that you will likely have immunity in the form of those antibodies for about 11 months. So that's something that the data have told us more recently. So that's just something that I wanted to share with the audience. And another aspect that we need to also discuss is the fact that the fact that we have these variants actually alter for lack of a better term, the goalposts for achieving herd immunity. So here you have like this nice little table with figures underneath each, detailing how the mutational landscape for each of the variants changes our goalposts for achieving herd immunity. Now, when on the far left, whenever it says the ancestral variant, that's basically referring to the original SARS coronavirus 2 that was first identified in Wuhan. And basically, based off of the experimentation, and epidemiological data, it was determined that one person can actually probably infect 3 people. So, it's just this whole idea that if you had approximately like 66%, 66.66666 of the population had been received vaccinations, then it would probably you'd achieve your herd immunity. So like 67% of the population, then we were going to get herd immunity, and then afterwards, remember, evolution ran its course, or as I believe Jeff Goldblum says in Jurassic Park, life finds a way, right? And SARS coronavirus 2 just burst forward with this alpha variant following evolving within immunocompromised patients, and then afterwards now one person could actually infect 4 people. So now the goalpost moves up to needing 75% of the population immunized in order to like really start to break down the the virus's I guess unbroken chain of transmission, right? And then lastly now, or not lastly, but most currently with the Delta variant, because it's even more infectious. Now, one person can, in theory, infect 6 people. And now you see that the herd immunity number has jumped up to 83% before we start to provide a barrier to protect both ourselves as well as those who are unvaccinated. So basically, what you're seeing here is that the goalposts for moving towards herd immunity have changed in line both with the dynamic nature of human behavior, most important, human behavior, and then also viral evolution, because viruses evolve, life finds a way. And herd immunity is basically an evolutionary moving target for most RNA-based viruses. And the reason why is that RNA is basically like the cousin of DNA, but DNA is very stable for the most part, unless it's mutated by smoke or ultraviolet radiation, et cetera, But for the most part, DNA is stable, whereas RNA has evolved within biology, kind of like a means of transmitting a genetic message. So I think I described this before, but DNA is like my mother's recipe for making some awesome jambalaya or some awesome shrimp creole, right? But let's say I want to go ahead and I want to make something, but my mother would be like, no. I'll give you, like some like a Xerox copy of it, like, but you're not going to take, like my specific recipe out of the kitchen. And like that Xerox or like that copy is basically like the RNA. And what's interesting is that for RNA-based viruses, the fact that you have that Xerox, copy means that it's not as stable. So that is what allows RNA-based viruses, like say HIV-1 or influenza virus, or of course SARS coronavirus 2, to be able to mutate so rapidly, right? And that actually has important implications too for these messenger RNA-based vaccines too, mainly because
Dr. Dispani,
yes,
could I get you to pause for a moment because
absolutely.
you're laying so much on us. But on your previous slide,
Yes.
I found that slide a bit concerning, and I want you to tell me that I'm wrong. You said that the Delta virus is just super good at attaching to the alpha-2 receptors. So that to me says that it is basically more infectious, because you are infectious once, being infectious means the ability to create an infection. So if it has mutated itself so that it can get inside our cells faster than the previous variants have been able to do, does that then mean, and I'm not talking about the vaccinated population now, I'm talking about, because this is why I'm concerned, I'm talking about the unvaccinated. Does this mean that we can anticipate more serious disease and less of the so-called asymptomatic disease with the Delta variant than we've seen previously? And I think you know where I'm going with this train of thought, but
yeah. So I've gone back into the slide to what the data sets that are from the cases and hospital admissions and number of patients based off of what we're seeing in the United Kingdom. And yeah, you're seeing that comparing, in the blue where it says the autumn wave, that's referring to the alpha variant. And then this current wave in red, that would be the Delta variant. So you are seeing an increase of cases, increase of daily admissions and total patients and whatnot. That is predominantly in the people who have not been vaccinated.
And the reason I wanted to highlight that is, again, we have you have data, and I've been given the data every week. We have a significant proportion of our population, our community, that has yet to be vaccinated. And I am concerned that with all of the different messages that are being received, you can go outside, you don't have to worry, that we are setting ourselves up for an even worse experience with COVID, this next go Delta, than we have seen. And it wasn't good what we saw before, but I think I'm concerned that we may be looking at something even worse. So I was wondering if you could comment on the risk to the unvaccinated community that we may be looking at.
Yeah, so and here's my image of an exasperated Dr. Fauci. That's the fear, right? Because we're receiving in our the media and like just even in some of the like state-based like I guess mandates and whatnot that they're able to go unmasked and so forth and so on. But that is basically letting off the evolutionary pressure on the virus. So
Dr. Dispani, let me pile on here a minute. This has been really good information. My concern,
yes,
and I think we still have to go back to our watchword, which is common sense. The airports were full last week. They had the biggest travel week since the pandemic. What are we doing? I mean, how can we protect ourselves? This is of concern to me, like it is to Dr. Neighbor Stevens, I'm sure others.
Yeah.
What is your best advice, given what's going on?
yeah, I mean, the best advice is that we should still be wearing masks, we should still be getting vaccinated, and we should still be practicing social distancing. And, like that's, I'll finish the rest of the slide deck quickly. And basically, right now, while people are worried about, for instance, the Delta variant growing, in predominance, people have also forgotten about the Gamma variant, and that's actually the second most prevalent variant. And if you see here in this map of the United States at the bottom, right, it actually, last time I showed this, where it was across the US, it was maybe in like 3 or 4 states. It's in 29 states now. And again, it also has that ability to bind tighter to your ACE2 receptors. It also has the ability to escape your, like your immune response. Your immune antibody efficacy rates. So again, you're worrying now about like 3 different variants as opposed to just one before. And again, how do we combat these variants? We have to continue getting vaccinated, wearing masks, and practicing pragmatic social distancing. And the thing is that there have been data sets mainly from the Pfizer vaccine. And this study was done in Qatar, which I guess Americans call it Qatar, but it's Qatar. And they found with this, the Pfizer vaccine was 90% effective against, well, this is in terms of protecting against any infection, like, whereas, how good is it and not even causing infection in the first place? And it was found to be 90% effective against the Alpha variant, around 75% effective against the Beta variant, and then around 88% effective against the Delta variant, greater about 14 days after the second dose. And then afterwards, the study also continued and showed that how effective is it at protecting against any severe, critical, or fatal disease after you get sick, which is, we don't want to get sick to the point where we die, right? No one wants that. And this study in Qatar found that the Pfizer vaccine was 97% effective about 14 days after the second dose. And then what you see here, it's basically I pulled data from the Centers for Disease Control, and it's segmented the data between the different age groups and whatnot. But what you see is that starting from January, onwards, in terms of like the weekly rate of COVID cases, C, the weekly rate of hospital admissions, and D, the weekly rate of COVID deaths within the United States, it all started to drop precipitously following the first vaccine availability in January, right? So we do see, again, these common sense measures are there, right? The data there, and they don't lie, right? There's a saying that's common in science that in God we trust, all others bring data, and another one in science too, that extraordinary claims require extraordinary evidence. So
Dr. Dispani, I'm wondering if you could entertain, if Janelle reads one of the questions from the chat, and Dr. Walsh and Dr. Neighbor have some other questions for you in the chat.
Yeah, sure thing. Yeah, and then
Janelle?
Sure. The plateauing is primarily due to natural reduction based on disease, natural progression, or vaccinations. Can you guess the reduction percentages from the natural progression of infections versus vaccinations?
Can you restate that?
Yeah, I can, yeah. Okay.
The plateauing is primarily due to natural reduction based on disease, natural progression, or vaccinations. Can you guess the reduction percentages from the natural progression of infections versus vaccinations?
I cannot guess
That
that without
sounds
looking
like
at
a physician question. Do we know who put that question in the chat?
Dr. Beatty?
Dr. Beatty, you want to translate that question? Can you unmute Dr. Beatty?
Let's see.
Okay, I guess Dr. Beatty is not available.
I tried to unmute, but I can't do it myself.
Simon? Okay, let's go to the next question and maybe we'll come back.
Okay, sure. So what makes a patient immunocompromised? Please explain what happens in the mutation process. Oh, maybe those are two different questions. What makes a patient immunocompromised?
That's basically whenever you have the immune system, like, for whatever reason, either due to an infection, i.e., e.g., HIV-1 or another type of virus that can actually destroy the T and B cells, or alternatively, it could just be that there's a thing called anergy, which is basically that the immune system just works itself so much that it just gets tired, just like almost like us, right? Where you just get exhausted and burnt out, and then it just can't fight off anything, right? And because the T and B cells can't really fight off anything, it just becomes playground for all kinds of different microorganisms. So that's why if you get a fungal infection, you can get these weird fungal infections that lead to like black tongue, or even for most people in the world actually are infected with cytomegalovirus. 90% of the world's population is infected with this cytomegalovirus, but it only causes disease really in like about 10% of the population because they're immunocompromised. So again, your immune system is there to be your vanguard to protect you against diseases and pathogens.
Dr. Walks, you chair our vaccine and treatment task force. And I'm wondering, given our speakers' talks today, both Dr. Gibbons and Dr. Dispani, is there any change in recommendations out of your subgroup or committee? Or we still need, I'm concerned that we want to pass on the right information.
So Dr. Maxey, let me first state how I have a big smile every time Dr. Dispani presents to us, because he gives us so much good information. It's like going to a barbecue and you're getting the good ribs. It's just so much good information to bite down on, and he explains things very well. From the perspective of the vaccine committee, one of the things that I had asked Dr. Gibbons about was, is anybody watching? Are people continuing to watch what's happening as folks are taking the vaccine, all these hundreds of millions of doses? And he gave a very, very encouraging answer. Yes, we're paying attention. We're seeing what's happening with folks. I think from the vaccine subcommittee, we're concerned that we're continuing to give good advice, that we're continuing to get good information. I have one of those practical down the street questions for Dr. Dispani. When you say something is more infectious, I think I'm understanding it to mean that you can get sick from a lower viral load. And so is that the same thing as saying, yes, masks and social distancing are important, but when we get these variants, I have to be even more concerned, because it may not take somebody sneezing in my face. It may take somebody just talking to me a couple of feet away, because more infectious means it takes less to get me sick. You don't have to cough on me when you're already half dead. You can just talk to me now, because this variant is more infectious. And back to Dr. Maxey's common sense, I need more common sense than maybe I did before, because more infectious means it's easier for you to get me sick. Am I on the right track with that, Dr. Dispani?
You are absolutely right. So whenever I describe infectiousness, I don't want to bore you guys with the viral kinetics and like the thing. The reality is that viruses are nanoparticles, and nanoparticles can evolve certain things that make it more sticky and able to bind more effectively. They call that avidity and affinity. So basically, what I'm saying, just to cut it down to the basic thing, the virus has evolved like a means of being able to cause infection with less viruses. So when the pandemic first started out, we estimated that it took about 500 virus particles to cause an infection. I don't even know what the number is now. It could be 200, it could be 50.
So on that same note, again, thinking about this from the vaccine subcommittee and us encouraging folks to continue to get vaccinated, I thought I heard you say earlier, Dr. Dispani, that there was a difference in the amount of immunity or how long the immunity lasts when someone gets naturally infected with COVID. And again, I didn't write this down, so I'm just kind of looking at my memory here, that maybe you get 11 months, potentially 11 months worth of immune response, versus with the vaccine, you may get 6 months, again, potentially worth of protection with the vaccine. And I had heard something about if you've been infected naturally and then you get the vaccine, you have even more protection. What I'm concerned about is someone may hear that, well, I'm young, I'm not going to die from it. So if I just go ahead and get sick, I'm going to get better protection than if I get the vaccine. Can you clear that up for us, please?
Yes, of course. Yeah. So the data do indicate that a person who gets this natural infection would have a longer term immunity. The reason why is because with a natural infection, the immune system can develop antibodies that can bind to all the different epitopes, or basically regions of the virus. So it's basically like taking snapshots, like a 360-degree, snapshot. It's like, oh, I'm going to recognize you. Whereas obviously, because humans are, we're not that as sophisticated as nature, whenever we design our vaccine, we're specifically designing against the receptor binding domain of the spike protein. So one part, and then, that's what your immune system is trained against whenever you receive the vaccine. Now, even though that is the case, the reason why you would not want someone to think that, oh, I think I'll be better from a natural infection, is because we know all of the bad sequelae, like it was discussed beforehand. There could be long COVID. Do you really want to risk a natural, infection, and then afterwards you're just always tired and you can no longer run as you could before? I mean, I run 3 miles every day, so for me that's a non-starter. And then secondly, there have been data. This was posted on medRxiv, but so again, it needs to still go through a peer review, but it was determined that in some individuals, they lost 8.5 IQ points after infection with the virus. Oh. So that's almost 9 IQ points once you round it up. Do you want to lose 9 IQ points? I love my IQ points that were gifted to me, and I don't want to lose a single one of them.
Well, we love your IQ points, Dr. Dispani. So please stay protected.
Yes.
So what I'm hearing is, and thank you for that. It's very clear that our body kind of looks at the entire virus particle and develops a response to it, whereas the vaccine gives us the one part. But still, the protection that you describe is huge with the vaccine. So my common sense, to go back to Dr. Maxey, my common sense take home from this part of the presentation is that if I've been infected and recovered and I get the vaccine anyway, that is really a great protection. And if I haven't been infected, I don't want to risk my IQ points. I don't want to risk my 3 miles a day running. And so I should go ahead and get the vaccine. That's what I'm taking home, right?
That is correct. And that actually is what I have counseled one of my colleagues who he had gotten infected during a trip to Latin America, and he recovered, and I told them to get the vaccine, and he did. So now, everything is good. So I always caution, or I recommend all of my my people in my network to still get vaccinated and whatnot. So you can never, at least I don't think, be too protected.
We have a question in the chat that follows up on this, and it's one of those common sense kinds of questions, I would call. Okay. Someone is asking, why does getting sick with chills or fever after the second Pfizer vaccine shot mean your immune system is good versus not having any sick reactions at all? And I think a lot of people are kind of confused about that too.
Yes. So basically, the reason why a person may have or may not have, like, it really depends on their immune system. What people don't realize is that the immune system, like our own human immune system, is still a Rubik's cube to us. Like, we don't really understand it, right? So some people may be able to get the vaccine and they'll be fine. And again, like I showed in one of the uh, prior figures, like that could very well also be due to the your natural age, right? So older people that tend to have, like a less robust a less robust immune, response and whatnot. Whereas younger people, they tend to have a more, so less if you're older, more if you're younger, and that basically is due to the fact that you're activating your body's, your body's alarm system, right? You remember whenever you were young, and then like pulled the fire alarm or whatever, and then everybody had to leave the school and go to the stadium. Is the same thing. So yeah, I mean, that's that. But then I have had young people my age who they got their vaccines and they were like, I didn't really feel much of anything. So really, we don't understand all there is to understand about the immune system. And how could we? Because the immune system is able to create things that recognize everything we ever like experience, right? Like, like plastic, you can have an antibody against that. Like, you can even have antibodies against your own body. Right? That's basically what autoimmune diseases sometimes are.
So let me be a patient a minute and ask you a question. I'm a genuine senior citizen, and I went to have my vaccine along with my wife and my son. And they gave me the vaccine, and I'm deathly afraid of needles. I can stick you, but you can't stick me. And I felt nothing. I had no symptoms. In fact, I even questioned, did they give me the vaccine? My son, he had a robust reaction to it. I had no reaction. Should I go and is there a way to measure titers or how good my vaccination took? Is there anything I can do to make sure I'm really protected? That's one question. Mm-hmm. Number two, the young lady that we had on before, Dr. Peggy Martin, I want to make sure she puts her information in the chat. But tell me what I should do to make sure my immune system is still protected going forward.
So with regards to the first question, I think you're probably looking for like what would be called a quantitative quantitative reverse transcriptase PCR. So that's a test, a diagnostic test that can actually quantify like how much either well, that's more like the virus, but I guess what you can do instead is you can test the you can probably test, you can do a blood draw, yeah, and then afterwards from there, in theory, you could then try to deduce how much your antibody.
Is that readily available?
Not really, no, because I mean, I have I have a cousin who's a celebrity, and he was asking me if there was a way that he could find a way to quantify the exact amount of his, antibody response, because he had a natural infection, and I was looking for him, and I could only find things that kind of gave a yes/no type of assay, like whether he had the infection or did not. So that I would have to do more looking, and then with regards to the second question you were asking, what can you do to ensure that you are protected, in an ongoing manner, right?
Yes.
Yeah, I would probably advise again, mask wearing, even though it's not cool anymore, and then social distancing, although that's not as cool anymore. And then lastly, just being prepared to get another vaccine booster shot in fall. So those should probably be ready around Q4, and those will probably protect against the beta and delta variants, which are giving us trouble. Yeah, and just definitely, if you feel the need, definitely get a antibody test. But like most of those are not all that, at least the ones that I've seen that have been marketed are not all that quantitative. Probably because, like doing the, most of these things are only for like laboratory applications and stuff.
Dr. Neighbor Stevens, are there any?
Yeah, there was another interesting question. I kind of have been wondering this too. So what's the deal with the Moderna vaccine? What's holding it up from getting emergency use authorization in this country? Because it has been deployed in Europe and in Jamaica, as Dr. Dawes tells us.
I probably am not, I can't answer that question because I'm shocked too, because with regards to the FDA is kind of weird right now because this is completely different topic, but the FDA just approved aducanumab, which basically is an antibody that is supposed to be against Alzheimer's disease. It specifically is, these are antibodies that target amyloid plaque. And, it seems ostensibly like it does something, but it basically was a surrogate marker, and that doesn't necessarily mean that you'll treat dementia. So that got approved. So why not the Moderna? And it just to clarify, Moderna does have emergency use authorization. Otherwise, I would not have been able to get my 2 jabs. I think what you're referring to is like its actual, like final like approval and whatnot. And I saw a question from, I believe it was Dr. blanking on her name, but I shall recall it in a few seconds. Dr. Sherrod, yes. Dr. Sherrod, she had a question that pertained to how can we monitor, like the long-term effects of these vaccines, especially the messenger RNA-based vaccines, and that actually is what phase 4 clinical trials are for. So using this Alzheimer's, I think it's called, the trade name is called Aduhelm or something, that was approved, but it never showed, it showed that it can stop, or it can like basically kind of sort of halt amyloid plaque formation. So the FDA said, hey, you need to do phase 4 clinical trials and prove that this can actually stop dementia. So it would be the same exact thing too, where, the FDA is an ongoing protection. It's not like they approve something and then they close their eyes and they go home, right? They still continue to monitor it. That's actually how thalidomide, which was a medicine that was used for morning sickness for women, was pulled from the market after they realized that it caused horrific birth defects in babies. So it's an ongoing thing.
Dr. Dispani, I sure appreciate your astute and perfect talk today. I'm sure we still have some questions to throw your way.
Yeah. Can I just give my last slide, because I just wanted to show. Okay. Sure. Is my slide still up for people? No.
You have to share it.
Okay. So this is just a nice little overview. Yeah, so I basically just wanted to provide at the end a visual refresher on SARS coronavirus 2 infection and how mRNA vaccines work. And basically you see that this is the mechanism of viral infection. You see this nice little picture of SARS coronavirus 2, which is basically like a little soccer ball, and like those little things sticking out of it. Those are the spike proteins I always talk about so much. And then the spike protein wants to get, and bind like Velcro or super glue to that little blue dot, which would basically be your ACE2 receptors that are so important throughout your body. And so that basically is spike 2 binding to your ACE2 receptors. You can see it, and after it binds, it goes intracellularly. And then what you're doing when you're actually taking one of these like Moderna or Pfizer vaccines is that you are taking a lipid nanoparticle. Lipid nanoparticle is basically like a fat, small, tiny, like piece of fat in which messenger RNA is placed inside, and it encodes like a synthetic version of spike protein for SARS coronavirus 2. It goes into your body intracellularly into the cell, and then it's actually that fat outer shell is broken apart, and then that is what allows your body's ribosomes to like read the messenger RNA, just kind of like a, you know, like a machine, right? Like, oh, okay, make this, make this, make this. And so it makes the spike protein synthetically. It goes to your plasma membrane, and then your immune cells start to recognize it. And once the immune cells recognize it and build up adaptive immunity, that's how you activate your adaptive immunity. And the adaptive immunity basically consists of these antibodies, which are these Y-shaped biomolecules, as well as it also activates, and the antibodies are produced by your B cells, and then it also activates your cell-mediated immunity, which consists of your helper T cells and your cytotoxic T cells. So cytotoxic T cells are like terminators that go in and like they go cell by cell and they kill SARS coronavirus 2 infected cells. And then the helper T cells, they kind of help both B cells and T cells like identify like who's infected, you know, and like where to go. So. And yeah, so all you need to do is, you know, like, even though it's not cool anymore, you have to continue wearing a mask, just like they typically do in East Asia. You have to, you know, still stay, 6 feet apart. Make sure you know the people, if they're vaccinated or not, because you can kind of, you know, be more, I guess, more closer if you're not, if both parties are vaccinated. Definitely avoid crowds and getting vaccinated because the virus will continue to mutate. This is what evolution does. Life always finds a way. The end.
I have a question about these variants. In the same way that they can be more infectious, if you mutate that corona, those spikes, doesn't that also have the potential of making it less infectious because it will rule itself out of getting into the ACE2 site?
I'm so glad you asked that, Dr. Maxey. Like, what people don't know is that there actually have been SARS coronavirus 2 variants that have actually like messed up. There was one in Singapore that I was watching last year. It totally messed up. It was trying to evolve to be more infectious, and it actually evolved to have a deletion. The deletion made it unable to even do anything, and then it went extinct. There's that going on all the time. It's completely random. Evolution is very random. It just, it sometimes hits the jackpot, it doesn't, but it's all random.
Well, thank you so much. Are there any other questions in the chat, Janelle?
I see that Dr. Gibson asked, is there not a period of time required for antibody formation? Yes, it typically is 2 weeks. It requires 14 days for antibodies to be, built up, because what happens is that you take an antigen. Antigen is just basically like the enemy or whatever, and it's recognized by your those helper T cells and the dendritic cells, and they bring it to B cells, and B cells are like, okay, give me 14 days and I'll get back with an antibody. And that's actually why you see that for like Pfizer and Moderna, it typically, they always say that like wait till 14 days or 2 weeks after you got your second dose for full protection.
Yeah. I wonder if Dr. Neighbor-Stevens or Dr. Walsh can speak briefly about June 25th, what we're doing. And
well, on June 25th, as we have previously announced, we are in collaboration with Dr. Moro Salafu, who is the head of medicine at Sunny Downstate Medical School and the School of Public Health at Downstate, to produce the first symposium on long haul COVID. Now, this was born right here during the Sunday broadcast about a month ago, maybe 6 weeks ago now. And we are very excited that we have pulled together some very renowned experts. This is a new field, it's a new disease. And so the work that's being discussed and presented is cutting edge. We won't have all the questions answered that we all have, but we at least know what's currently known in the direction that people are looking to try to overcome these chronic symptoms that unfortunately some people are experiencing. Dr. Walks, you want to add anything?
I just want to add that what we're going to be doing on the 25th is not only just looking at what we have figured out so far about long COVID, but looking forward at some of the concerns and hopefully encouraging folks to do additional research and to focus more on what's happening, which goes back to what Dr. Gibbons told us about some of the partnerships that his organization through NIH is building within communities. So I think it's a real opportunity to, I remember during training that whole town versus gown. Are you out in the community or are you in the academic center? And so what we're doing on June 25th is bringing the academic centers and the community together to look at how something that is impacting so many members of our community, how it's impacting them, what we know about it, and what we need to learn as we continue to look forward.
Okay, I'd like to recognize Dr. Sherrod for a brief question. Can we make sure she's unmuted?
I can see Dr. Sherrod's box and I don't see her video on and she is still muted. Oh, here we go. Here she comes. So we'll need to unmute Dr. Sherrod, please.
Hello, Dr. Sherrod, are you unmuted?
Not yet. There we go.
Okay, thank you, Dr. Maxey. There were two things. One, I wanted to address the thing about the plateau. The question, can you hear me?
Yes,
Yes.
Dr. Sherrod.
Can you hear? Okay, so the first thing I wanted to, I agree with the doctor that just finished talking concerning
Dispani.
testing to document whether you are immune or not. That is not clinically available at this time. It's not clinically available. It's only available in laboratories, as he said. So there's no way for you to document laboratory-wise how you're reacting to the vaccine. The second thing I wanted to address was the question that came up concerning the plateau and whether you can differentiate whether the plateauing of the epidemic is secondary to the natural generation of the virus or whether it's due to the vaccinations that we are receiving. And that, I think that's my.
Did she cut off?
Dr. Sherrod, your connection is not a good one. You cut off there. We'll need to unmute Dr. Sherrod again, please. Okay, Dr. Sherrod, go ahead.
The question concerning plateauing is whether you can measure whether the plateauing or the percentage of the plateauing due to the natural course of the virus or due to the vaccination. I think that's what they're asking. And I think that question is up in the air because there's so much we don't know about this particular virus. And with the information that we're getting now that it probably may have come out of a laboratory and may have had gain of function alteration. So it's not going to be a natural.
I think we're still
very
struggling
bad
with Dr.
connection
Sherrod's
with
connection.
Dr. Sherrod. Are there any few final questions in the chat? I want to make sure that Dr. Martin got to put the location of her testing and vaccination center in the chat, and we'll put it on the website. If that's
Got
okay. What's that?
I've got a question here.
Go ahead.
Delta is more infectious, but not more lethal. However, can the virus mutate to increase its lethality or its infectiousness or both? If so, what would that look like?
Yes, it can do anything given enough random mutations. And what would that look like? That would I would probably envision that the spike protein would become even tighter binding. So now you probably get it to where you get like just 3 virus particles can cause an infection. So that could very well happen, or it could not. And lethality would probably be, if you wanted it to do that, or evolution wanted it to do that, I should clarify, it would probably be that it would, cause even more, I guess, like cytopathic effects. Cytopathic effects is basically like problems that it causes within a cell. Like one thing that we have found, which I saw, this is very common in coronaviruses, and I saw this with a cow coronavirus that I worked on when I was younger. These coronaviruses, actually what they do is they don't just transmit via infecting you directly. What they do is they infect one cell, and then they force the other cells nearby to fuse into one to become a gigantic supercell, and that makes it easier for it to transmit and cause all these problems. As you can imagine, your cells are supposed to be individually and divided. That would be like if you, Janelle, and I, and Dr. Maxie and whatnot were just forced to like become one thing, and like it just all be like, one thing. It's just very scary, and that's basically what the virus can do, and and whatnot. I will clarify though that the gain of function and so forth and so on, that's not necessarily like that's a theory, but that has not been proven. That's why I say extraordinary claims require extraordinary evidence, because I can tell you guys certainly that like I genetically engineered coronaviruses when I was like 19 to 20, and people can actually genetically engineer viruses all the time. Those are all gain of function. We sometimes pseudotype viruses. We basically take one virus and we stick it with other things, so that like you can have like an HIV that can in theory infect respiratory cells. So we do these things. So you have to be cognizant, and also keep in mind that with these viruses, my personal hypothesis is that there were these coronaviruses that are discovered because there was SARS coronavirus 1, and there recently was a paper published that 24 new coronaviruses were discovered in Yunnan province. Yunnan is a province in China that has like a caves like with lots of bats, and some of those actually look very similar to SARS coronavirus 2. So, like probably like a more likely scenario is that, they basically did bioprospecting, finding new, like bats with viruses and stuff like that. And then somebody got sick because they were sloppy, because Wuhan Institute of Virology didn't have the best, like I guess housekeeping habits. And then maybe somebody got infected. Like people getting infected from working with viruses is very common. So it doesn't necessarily have to be that it was like intentionally done, because remember, like the coronaviruses are very fickle when they're like genetically modified. I know this because I wasted 3 years of my life trying to genetically modify a coronavirus to actually treat colorectal cancer, because my one of my uncles had colorectal cancer. So it's not, people make it seem like it's so easy to do, what we do. It's not.
Since I'm back, Dr. Maxey, can I finish? What I was saying is that I don't know if we know enough about the seasonal variation of this particular virus in order to be able to separate out the plateauing naturally of the virus versus that's attributed to the vaccination.
Yeah, I agree with Dr. Sherrod. Yeah, we always have like these seasonal, and like science cannot explain why viruses like influenza or coronaviruses like just go dormant or whatever. So yeah, I agree wholeheartedly with Dr. Sherrod. You can't get around that.
Well, I thank again, Dr. Dispani. I thank you. I thank our other distinguished guest, Dr. Gibbons, who is our top cardiovascular scientist at NIH, Dr. Neighbor Stevens and Dr. Walsh. Do you have a final word before we introduce our stars of benediction?
I want to just say that the last comment, well, next to the last comment in the chat, seeing that means that I think we're getting the message across. We want to give you the information that you need to make the appropriate decision for you. That is our goal. That is our mission statement. So if you have heard information today that makes you alter your behavior based on the information that you were given, then we have met our goal.
And I just want to emphasize the common sense. I want us to consider the fact that we have had so many people over several months tell us a few things that I think matter. Tell us that people who look like us and have a history of caring for our community and being aware of how to help us move forward, those people have been involved in what's been going on with the coronavirus, with the vaccine. And as the chair of the Vaccine and Guidelines Committee, with all of the information that has come out over the last several months, we continue to say that we recommend you talk to your doctors, your local healthcare professionals, and make a decision that works for you around the vaccine. We're encouraging folks to take the vaccine. And what we heard today was really encouraging, that experts like Dr. Gibbons and like Dr. Dispani are continuing to look for good information about what's happened since we started vaccinating people. What's happened since we gave 100 million and something people the vaccine? What's happened since we gave over 300 million doses of vaccine to people? Is it safe to get the vaccine? Yeah, the answer is yes. Should we continue to vaccinate folks? Yeah, the answer is yes. Should we continue to wear masks and keep our distance? Yeah, the answer is yes. And so we've gotten a lot of information that we can use individually. And I think it's important for us, as Dr. Neighbor-Stevens said, to continue to get information and make those decisions. So I'm just once again very thankful that this forum exists and that folks can get that information.
Well, thank you, Dr. Walk. I want to remind everybody that we have a website that is called blackhealthtrust.org. Please review it. There's information on it, even though we have a lot more to do. And I would call your attention that we broadcast live or stream live on Facebook. And also we're on YouTube and some other platforms. And we'd love you to like us and tag, whatever that means, and get the information out so we can increase our spread of information to our communities of color. Give us a thumbs up. I think that's important. I'd like to also ask our virtual assistant to put the save the date flyer for the first international symposium on the Longhaul Syndrome in the chat, and make sure we send that out later this week. I'd like to thank my wonderful co-moderators, Dr. Neighbor-Stevens and Dr. Walks. I'd like to thank our technician, Mr. Simon Cooper, and our virtual assistant, who, by the way, is a Phi Beta Kappa, Ms. Stevens, for working with us, and Mr. Skylar Maxey for creating our graphic art. And I'd like to invite Ms. Brenda Leager to give her usual closeout. And I have a spiritual word for Dr. Pastor Pointer. He always liked it when I say something spiritual. Cleanliness is next to godliness. So after Ms. Ager, I'd like Dr. Pointer to speak.
Good morning, and thank you, everyone. Thank you, wonderful doctors and everyone on this, in this beautiful platform that I'm learning so much about. And the word came to me today, grace. So I'm just going to do a little bit. Amazing grace, how sweet the sound that saves and sets me free. I once was lost, but now I'm found. Was blind, but now
Pastor Pointer?
Amen. Let us give thanks. Eternal God, our Father, we thank you again in Black Health Trust for another time of learning and of information receiving. We thank you specifically for your servants, Dr. Gary H. Gibbons and Dr. Jordan Dispani, that they continue to come and to fellowship with us with knowledge. And we pray that we will leave from this forum and go and infect others with knowledge. Let us be protected in this circumstance that we're in. Let us continue to find good works for our hands to do. My brothers and sisters, the grace of our Lord Jesus Christ be with your spirit. Amen. This has been an excellent afternoon.
Thanks, everybody. Have a good Sunday.
Thanks, everyone.
Bye.
Bye.
Thank you.